Before starting, kindly introduce yourself.
Sure.
And where are you from and what presently you are doing?
Absolutely, I will. Yes. Hi, happy morning, everyone. My name is Hetansh Rao. Not a doctor yet. I'm a student. I'm a doctor of pharmacy, final year student at LM College of Pharmacy, Ahmedabad. And I'm here presenting a research study which I have done in my 5th year of PharmD curriculum, which was investigating the prescribing trends and therapeutic outcomes with the use of SGLT2 inhibitors in diabetic patients. The study was carried out in the city of Ahmedabad, Gujarat, under multiple clinics, 3 to be more specific. And the study duration was 6 months, wherein we screened 210 patients, of which 120 patients were chosen on the basis of inclusion and exclusion criterias. The criterias which we included in choosing the patients for the study includes the inclusion criterias include that the patients had to be on SGLT2 inhibitors. The patients can be newly diagnosed case of diabetes, or can also be a previous case or an old case of diabetes mellitus. The patients we chose were DM1 or DM2 positive, and the exclusion criteria mainly were the patients should not be on any anti-neoplastic drugs, because as we all are aware of that the anti-neoplastic drugs can very prominently affect the diabetic, the pharmacology of the pharmacotherapy of the diabetic drugs. And also some psychiatric drugs are also known to cause pharmacotherapeutic changes in this diabetic drugs, so they were also excluded. It is a retrospective observational study, and so a very quick recap for all of us. SGLT2 inhibitors, they inhibit the proximal tubule in the renal tubule cell, wherein ultimately they remove the glucose, and basically you urinate the excess glucose out, which eventually stabilizes the blood glucose levels. So the target SGLT2 proteins in proximal renal tubules, they inhibit the glucose reabsorption, which is pretty much almost 90% of the total capacity. The pharmacokinetics is very interesting for SGLT2 inhibitors, since the very prominently or the very well-known used SGLT2 inhibitors are the dapagliflozins and the empagliflozins in the Indian scenario, in the Indian patient population. So the bioavailability is quite high, from 75 to 78%. And since their half-life is pretty long, I'm talking specifically about dapagliflozin, the average half-lives of SGLT2 inhibitors, as we all know, ranges from 10 to 16 hours, averaging at 12.9 to 13 hours. So once daily dosing is a very positive side for SGLT2 inhibitors. The study which was carried out had the primary objectives to analyze the prescribing. It had 2 primary objectives, as already stated in the title: to study the prescribing patterns and to analyze the safety, efficacy, and the pharmacotherapy of the therapeutic outcomes of the drug on the patients. Ultimately, also to assess safety profile and adverse events, and determine clinical effectiveness in real-world scenarios. The study design, as stated, it was a retrospective observational study in 120 patients. I'll not repeat myself. Outcome measures which were also calculated included HbA1c, weight, lipid profile, and UTI incidences of those 120 patients screened. Okay. Evaluate therapy. The population was type 2. This is okay. The key findings, let's start directly from there. The key findings was, dapagliflozin was the most prescribed the drug in the Ahmedabad, Gujarat area, at least, or at least the study centers which we chose in. with 32.48%, followed by empagliflozin with 16.1%, and the last one, which was also very surprising to me, was remagliflozin, which was at 6.08%. Combination therapy was preferred over monotherapy anytime, because as the guidelines suggest, and empagliflozin and canagliflozins were equally prescribed at 2 point something percentage. Growing acceptance in the clinical practice because of their very prominent pharmacotherapy in the area. The SGLT2s inhibitors are still very prominently used in the market. The dapagliflozin being the most prescribed drug still is probably because, from my knowledge, is its early entry in the market, which also has, it basically has an upper hand of entering the market or penetrating the market as compared to any other gliflozins, which was eventually followed by empagliflozin, which is probably due to the better cardiac factors. The empagliflozin is much safer as a cardiac drug, hence it is the second most prescribed drug. As we can see in the graphs over here, the DAPA, EMPA and REMO and canagliflozins as monotherapies were prescribed from 30 and to so and so percentage, whereas the combination therapy in red depicts that the DAPA plus MET, other combination DAPA plus CETA and EMPA plus MET has a lesser penetration percentage for patients. The therapeutic outcomes for the glycemic and the glycemic control. Okay, the study which we carried out showed that the baseline, when we started, the patients had a baseline HbA1c. Yes, sir. You
Running late.
I will try to open. Yeah, I will. The baseline, the patients when started on before, when the patients were administered in the study, they had a baseline HbA1c of 7.8, and within 12 months the patient had a baseline of 7.2 percentage, which is a definitely statistically significant value, not clinically, I agree, but yeah, so basically the 0.6% absolute reduction, p less than 0.0001. Hence, the data being nominal, we use the non-parametric tests like Mann-Whitney, and so clinically meaningful improvement was eventually seen in the patients. Sustained effect throughout the study period. The graphs very clearly depicts the baseline followed up at 3 months, 6 months and 12 months for the 120 study population. The additional benefits, these are the secondary parameters for the patients, wherein the cholesterol also showed a prominent decline of 24.2 mg per dl, weight decline of 2.3 kilograms, which is again statistically might not be very significant, but clinically significant, which is vice versa of the previous one. And improved fasting glucose levels. We also checked RBS and FBS of the patients on every visit. The safety profile of SGLT2 inhibitors included UTI incidence, wherein 4.17% versus 3% control. It was very well tolerated in the study population. No severe adverse effects were as such reported. The clinical implications, the study conclusion, and so all in all, since I'm running a little late, I will be super quick. The study conclusions concluded that the dapagliflozin is still a very preferred choice of drug in clinical practice, and because of its acceptable safety profile with low UTI risk and everything, it is a very promising drug to be prescribed in combination with the other drugs. So the future directions, here are the references, and pretty much that is it. Thank you so much.
So when did you do this study?
Sir, so in our Doctor of Pharmacy curriculum, the 5th year is dedicated for a research study, wherein...
Tell me the duration. From which, this year, last year?
Last year. I'm in my final year right now, so I did it last year. Yes, sir.
So this is 1 year data?
Yes, sir.
So, because I was more interested because DAPA, yeah, it is still most commonly prescribed SGLT2 inhibitors, but once the EMPA and now off patent, so now the trend of empagliflozin is also going up. And I was surprised to look at there was no combination of DAPA and LINA in your study. So you
Yes.
didn't find a single.
No, we could not. Okay, that might be a challenge, not a challenge rather, but a shortback or a shortcoming of our study, wherein we studied only for 120 patients, and that too we only had partnered up with 2 clinics, which is just 2 physicians, though very prominent names in Ahmedabad, but 2 physicians like majorly. So I mean, we could not explore more physicians prescribing patterns in Ahmedabad. That's the limitation of our study. I get it.
Yeah. So in the starting of presentation, you said you involved type 1 diabetes.
Yes, sir. I mean, that was an inclusion criteria, but yeah, later on I fumbled up. I'm so sorry. We did not include. Yes.
Just be very clear
Yeah,
what you do,
no,
what
we
you
did,
don't
yeah,
do,
of course,
what
of
are
course.
inclusion, what
I
are
totally
exclusion. This cannot be done.
I totally get it.
What
I'm
are
so
the
sorry.
basic dosing of these medications? What is the dosing of DAPA, EMPA, CANA?
Okay.
Taken 120 patients.
Okay.
What is the normal dosing of all those medications?
I will have to check, sir.
The basic thing.
Yeah, it's a basic thing, yeah.
You said about the cholesterol. What's the most important component of lipid profile for a diabetic patient?
VLDL. I mean, are we talking about the lab parameter?
Obviously, it would be lab parameter. What would you be talking about?
Yeah, so the LDL, VLDLs.
LDL is the most important.
Yes, sir.
You have not included that in the study.
Yes, we did not.
What happens to LDL?
It increases.
And what about the triglyceride?
It
You've
also
shown
increases.
that cholesterol decreases with the drug.
Correct.
What
Yeah.
happens to LDL? What happens to triglyceride?
LDL increases, triglycerides also increases. It decreases, TGs decreases. It's inversely proportional to each other.
So LDL is the good cholesterol or the bad
It's
cholesterol?
the bad cholesterol.
So will it increase with the medication or will it decrease?
It will decrease with the medication. I mean, in case of the dyslipidemic patients, the LDL shoots up. That's when we diagnose that the patient is
What happens with an
dyslipidemic.
SGLT2 inhibitor to LDL?
I'm so sorry, I could not get you.
What happens to LDL with the use of SGLT2 inhibitor?
It decreases.
No,
Yes.
no. It increases.
Okay.
You have to read about this.
I will.
Then you told about the CVOT. Whatever drugs you are using, can you just name the trials? Leave the data.
Okay. About what drugs?
CVOT trials.
Sorry?
CVOT trials. Just the name is okay. What are the trials for DAPA? What are the trials for EMPA? What are the trials for CANA?
EMPA reg trials.
Yes, good.
Then we have that's all I can recall right now. I'm so sorry. But EMPA reg is the very prominent one which we have all studied. Yeah.
You have to read. Overall, the presentation was good.
Thank you.
But you are using too many diagrams here.
It's declared for DAPA, EMPA-REG for empagliflozin,
Okay.
and CANVAS for canagliflozin.
Correct. Okay. Ma'am. I will.
And you have not looked into the doses, and you have not compared the molecules. I mean, have you compared the incidences between DAPA, EMPA separately? You have not looked into that.
No, ma'am.
Which one is causing more UTI? Which one is causing more weight loss? You have not looked into that.
Yes, ma'am.
And even the side effect profile is not the same when you give the drug individually and when
At
you give it in
different
a
doses.
combination.
Got it, ma'am.
Have you looked into that specifically?
Ma'am, we did study that, of course, but we did not include it in the study because it was a limited time, and so yeah.
You have taken only few combinations. You have not
Yes, ma'am.
studied the extensive way of treatment.
Yes, ma'am. Yes, ma'am.
And type 1 data was not presented. You have just mentioned it in the inclusion criteria.
Yes. Okay. Yeah.
So yeah, the presentation was good, but I think
Thank you.
you need to study more extensively before doing that.
I will. Thank you so much. Thank you.